Kentucky. A woman who grew up in Somerset is now an associate professor of microbiology and immunology at Georgetown University in Washington, D.C. We're going to visit now with Dr. Julie Fischer about the coronavirus outbreak. And Dr. Fischer, thank you so much for being a part of this today on Hey Kentucky. We really appreciate your insight.
I'm so thrilled to be here. Thank you for asking me.
So let's start with this. We've all seen a shift from let's lessen the groupings of, less than 50 people, then less than 10 people. And we've moved into this kind of now shelter in place across a lot of parts of the country now. Should we have done that earlier on?
I think it was difficult to tell early on because the delay in having laboratory testing available to people to understand how many people were infected at the community level meant it was really difficult to get a sense of how quickly the virus was spreading through community level transmission. Now that we know, we've looked at the mathematical models and understand that these measures that were a little more gentle, a little less disruptive, might not be enough to slow down the spread of the virus to protect those who are most vulnerable of severe disease and make sure that there's adequate healthcare resources to care for them should they become seriously ill.
Testing still seems to be an issue. And I wonder, is that because this is such a novel virus, a new virus, that we just didn't have it available and it's taking so long to get those test kits made? Or what do you think the delay is?
Well, there were some technical delays in the U.S. getting those diagnosed tests out. We really rely on the US CDC to do the research to help us make the tests in the first place, for a novel virus like this that no one has seen before, to use the data and make a kit that can then be shared with state and local laboratories across the US. And unfortunately, there were two issues. One, there were some technical issues in getting that CDC test out that unfortunately delayed being able to get it into the hands of public health and clinical practitioners. And then the second thing is, unfortunately, some of the policies that were really designed to get those tests out quickly unintentionally slowed down state public health laboratories in developing what are called in-house tests, the ones that they develop using their own knowledge and expertise with published data. FDA has addressed those policy problems. On the 29th of February, they expanded what's called emergency use authorization to public and private commercial manufacturers nationwide. And now we're seeing more and more of those tests coming online and available. But it was just really an unfortunate combination of events that delayed launching those lab tests and has put us at the point of being caught a little behind in understanding where the disease is spreading and how quickly.
Do you think we have a better idea of that now? I keep hearing from all over the place that enough people aren't being tested yet. Do we still do we have an accurate picture of how widespread this is here yet?
We are still really trying to get that picture at the community level, unfortunately. There's two aspects with testing. The first is the technical challenge in getting tests approved and validated, and that's getting better. Right now we have upwards of a dozen tests, or about a dozen tests that have been approved for use by private sector labs and by public health laboratories across the US. So more and more tests are being conducted every day, but then there's also the logistical question. How do you get people to the point of care where they can be tested when so many of our healthcare workforce are busily trying to care for people who are symptomatic? And how do we make sure that their specimens can be collected, transported to labs, and tested, and then the results get back to both the clinical personnel and public health officials who can then use that information for action? So there's a lot of steps here. More and more testing is happening every day. That's the good news. Prioritizing those tests for people who are already severely ill, which is important, but leaves us unsure of how many people may be infected asymptomatically or with only mild illness in our communities.
And do we know why that happens? Why some people can have the virus and not show any symptoms, while other people, even if they aren't necessarily immunocompromised, it's really wreaking havoc on them?
There's so much we're still learning about this virus. It looks like it binds in the upper respiratory tract, so the nose and the throat, and that a lot of the people who are asymptomatic may just have virus in the tissue in their nose and their throat where they can cough it out and breathe it out, but they aren't really severely ill. It's the people who have inflammation in their lungs, which can lead to life-threatening pneumonia, who are really getting sick. Right now, there's still scientists are really trying to answer the question of why do some people go on to get pneumonia while others don't. It may be the amount of virus they were exposed to. It may be something about their own genetic makeup. But right now, we're still really trying to understand why some people are at risk of very severe disease beyond the obvious risks for people who are older, who are 75 or older, who have underlying conditions like lung diseases, diabetes, and hypertension.
Dr. Julie Fischer, thank you so much. More Hey Kentucky right after this.